5 years ago, a 74-year-old retired schoolteacher sat across from me in my clinic. She'd driven 40 minutes to get there. Her daughter was with her, holding a manila folder full of paperwork, surgical consent forms, pre-op instructions, a surgery scheduled for the following Thursday. She was nervous. Hopeful, actually, because 3 different doctors had told her this procedure would finally fix what had been making her miserable for years. I looked at her chart. I looked at those consent forms, and I had to tell her something that nobody in that chain of appointments had said. I don't think you should have this surgery. She looked at me like I'd just told her the sky was green. Her daughter started to cry. And I spent the next hour explaining something that I wish every patient over 60 had access to before they ever signed anything. I'm Dr. Elliot Marsh.
I've spent over 2 decades as a cardiologist, and what I've seen in thousands of patients in hospital corridors and recovery rooms is that there are surgeries being routinely recommended to people in their 60s, 70s, and 80s that carry risks nobody is talking about openly. Not because your doctors are bad, they're not, but because a 15-minute appointment leaves no room for the conversation that actually needs to happen. Today, I'm going to have that conversation with you. 5 surgeries, common ones your own doctor may have already mentioned, where the risk after 60 deserve far more scrutiny than they typically get. And number 1 on this list is going to surprise you. It surprised me the first time I saw the data. Stay with me, because after these 5, I have a bonus section that could change how you walk into every medical appointment for the rest of your life. This is information I wish I could give every patient before they pick up a pen. Here's what we're covering today. 5 surgeries commonly recommended after 60, and what to ask, what to consider, and in some cases, what to firmly push back on before you agree. We're counting down from number 5 to number 1. And number 1 is a procedure that millions of older adults undergo every single year, often believing it's low risk. The data tells a very different story. After the 5, I'll give you the framework I use with my own patients. The exact questions that change outcomes. Stay with me. Let me give you 60 seconds of science so this makes sense. When you're under 50, your body is remarkably good at one thing: recovering. Your cells repair, your blood clots, your immune system fights, your heart bounces back from stress. But here's what changes as we age, and I want you to really hear this. After 60, every one of those systems becomes less resilient. Think of it like a car with 200,000 miles on it. It still runs, it might run beautifully, but you don't take it off-roading the same way you would a new vehicle. The margin for error is smaller. Surgery, any surgery, creates a controlled injury to your body. Your surgeon cuts, repairs, reconnects. Your body then has to mount an enormous response. Clotting, inflammation, healing, immune surveillance. In a younger body, that process is like a fire drill. Everyone knows the exits, moves efficiently, recovers fast. In a body over 60, that same process can look more like a 5-alarm fire in a building where some of the sprinklers don't work the way they used to. That's not defeatist, that's biology. And here's what should motivate you. Knowing this changes everything. Because the question stops being, should I have this surgery, and starts being, have I truly exhausted every option that doesn't carry this level of risk? That question, that simple shift in framing, has saved lives in my clinic. That's exactly what these 5 conversations are about. Number 5, spinal fusion surgery for back pain. Back pain is one of the most common complaints I hear from patients over 60. And I understand it completely. Chronic back pain is debilitating. It affects sleep, mobility, mood, everything. So when a surgeon says, we can fix this, of course you want to hear more. Here's what most people don't realize. Spinal fusion surgery, now where 2 or more vertebrae are permanently joined, has a complicated track record in older adults, particularly for degenerative conditions like arthritis or disc wear. Let me explain what happens inside. When you fuse 2 vertebrae, you eliminate movement at that joint. But the joints above and below that fusion now carry more stress than they were designed to handle. Think of it like fixing one link in a chain by welding it solid. The stress doesn't disappear, it just moves to the links next door. This is called adjacent segment disease, and it affects a significant percentage of fusion patients, often within 5 to 7 years. A study published in the Journal of the American Heart Association found that older surgical patients face compounded cardiovascular risk under general anesthesia, risks that are frequently underestimated during surgical consultations. Here's what the research also shows. For many types of degenerative back pain, intensive physical therapy, anti-inflammatory lifestyle changes, nerve blocks, and targeted exercise programs produce outcomes that are statistically comparable to surgery, with a fraction of the recovery burden and none of the surgical risk. The fix isn't always the knife. The common misconception here is that minimally invasive means low risk. It doesn't. Minimally invasive describes the incision. Your heart, your lungs, your blood. They don't know the incision was small. Before you agree to spinal fusion, ask your surgeon this direct question. What is the non-surgical treatment pathway, and what evidence do we have that surgery will give me significantly better outcomes than that pathway in someone my age? If they can't answer that clearly, get a second opinion. Have you ever been pushed toward back surgery or know someone who has? I'd love to hear your experience in the comments. Number 4. Cardiac catheterization and stenting for stable coronary artery disease. Now, I want to be very careful here because there are absolutely situations where stenting is urgent, necessary, and life-saving. If you are having a heart attack, right now in the emergency room, a stent can be the difference between life and death. I am not talking about that. I am talking about something different. Elective stenting for stable coronary artery disease. This is when imaging shows blockage in one or more coronary arteries, you have no acute symptoms or a heart attack, and a procedure is offered to open those vessels up. Here's the part that genuinely stopped me when I first read the research. A landmark trial, the ischemia trial, published in the New England Journal of Medicine, followed thousands of patients with stable coronary disease and found that stenting did not reduce heart attacks or death compared to optimal medical therapy alone. That's medications plus aggressive lifestyle management. The stent group and the medication group had virtually the same outcomes. Write that down. For stable disease, not a heart attack, not unstable angina, stenting may not extend your life. Now here's what this means for you. If your doctor has identified blockage on a scan and is recommending a procedure and you are currently stable, not in the ER, not having chest pain at rest, you have every right to ask, are we treating symptoms or are we treating numbers on a scan? You have every right to ask about the evidence for doing this versus optimizing my medications and my lifestyle. You have every right to say, I'd like 90 days of supervised cardiac rehabilitation before we decide. That conversation, in my experience, doesn't always happen. It should. Before we move on, I want to tell you something that surprised even my longtime patients. This next one is a surgery that feels completely routine. And for many people it is. But after 60, the risk profile changes in a way that the brochure doesn't tell you. Number 3. Knee replacement surgery. Knee replacement is one of the most commonly performed orthopedic surgeries in people over 60, and in many cases it provides real meaningful relief. I'm not dismissing that. What I am saying is this. The decision deserves much more scrutiny than it typically gets, and there are specific situations where it is being over-recommended. Think of your blood as a traffic system. After major joint surgery, your body's clotting system goes into high alert. In younger patients, that system is well regulated. In patients over 65, and especially those with any existing cardiovascular conditions, the risk of deep vein thrombosis, blood clots in the legs, and pulmonary embolism, clots traveling to the lungs, rises substantially. As a cardiologist, these are the cases I see come through the door post-surgically. Not all of them survive. Here's what most people don't know going in. Outcomes for knee replacement are strongly predicted by preoperative muscle strength and cardiovascular fitness. In other words, your result after surgery depends enormously on what your legs and heart looked like before surgery. One of my patients, a 68-year-old former postal worker, was scheduled for bilateral knee replacement. Both knees, same procedure. I sent him to a physical therapist instead with very specific instructions. 8 months later, he canceled the surgery himself. Not because I told him to, because his knees weren't stopping him anymore. That is not a universal outcome. But it happens more than surgeons mention. The common mistake here is assuming that once a surgeon says you're a candidate, the surgery is the only rational next step. Candidacy means your anatomy could support the procedure. It does not mean it is your best option right now. This is something most doctors don't have time to explain in a 15-minute appointment. That there is a structured, evidence-based prehabilitation pathway that can dramatically change your outcome and sometimes eliminates the need for surgery entirely. Ask about it before you sign. My friends, before we get to number 2, please hit the like button. This kind of information needs to reach people who are sitting on consent forms right now and don't know the questions to ask. Subscribe if you haven't. I put out a new guide every week. Now let's go to number 2. Number 2, carotid endarterectomy for asymptomatic stenosis. Your carotid arteries run up both sides of your neck and supply blood to your brain. Over time, they can develop plaque buildup, a narrowing called stenosis. When this is severe, it can contribute to stroke. The surgery to clear that blockage, called a carotid endarterectomy, involves opening the artery and physically removing the plaque. For patients who have already had symptoms, a mini stroke, sudden vision changes, sudden weakness, this surgery has clear, well-established benefit. I support it in those cases. But here's where it gets complicated. Routine ultrasound screenings, increasingly common, sometimes offered at pharmacies or health fairs, are detecting asymptomatic carotid stenosis in older adults. No symptoms, just a narrowing on a scan. And some of those patients are being steered towards surgery. What I've seen in clinical practice and what the research and publications like Circulation supports is that for asymptomatic stenosis below a certain threshold, the risk of the surgery itself, including stroke occurring during or after the procedure, can equal or exceed the stroke risk of carefully managed medical therapy. You can die from the surgery to prevent the event you were trying to prevent. The fix? Ask one question. Am I symptomatic, or did you find this incidentally? If incidentally, what does the evidence say about watchful waiting with aggressive medical management versus surgical intervention for someone my age with no symptoms? Then listen very carefully to the answer. If they can't point you to specific evidence, ask for a second opinion. And now, number 1, the one that I have seen cause the most harm in patients who had every reason to believe they were making a safe choice. Number 1, elective surgery under general anesthesia for non-life-threatening conditions after age 75. This is not a single procedure, it is a category, and it is the most important thing I will say today. General anesthesia is not a simple sleep. It is a pharmacological disruption of your brain, your cardiovascular system, your respiratory system, simultaneously. In a healthy 40-year-old, recovery from that disruption is rapid and complete. After 75, and in many cases after 65, depending on baseline health, the picture changes dramatically. There is a condition called postoperative cognitive dysfunction, POCD. It sounds technical, so let me explain it the way I explain it to my patients. Some older adults, after general anesthesia, experience a measurable decline in memory, processing speed, and executive function. Sometimes this is temporary, weeks or months, but in a subset of patients, particularly those over 75, it does not fully reverse. The thinking doesn't fully come back. This is not a rare outcome. A study published in The Lancet found that rates of postoperative cognitive decline in older adults are far higher than most patients are warned about prior to surgery. Here's what makes this urgent. The conversations about this risk are happening in research journals. They are not consistently happening in pre-surgical consultations. Somewhere between the operating theater and your kitchen table, this information is getting lost. Now, before that frightens you into never treating anything, here's what this means practically. It means that for elective procedures, things that are genuinely optional, things where the alternative is manageable discomfort, rather than urgent medical need, the bar should be higher after 75. Not infinite, higher. It means asking, could regional anesthesia work here instead of general? It means asking, what happens if we wait 6 months and try conservative management first? It means making sure that everyone on your care team knows your cognitive baseline before they touch you with anesthesia. You can start having these conversations tonight. Call the family member who is accompanying you to your next appointment. Share this with them. They need to know these questions as much as you do. Now, the bonus content I promised you. 3 quick but powerful tools that change how you navigate every surgical recommendation. Bonus number 1, the 48-hour rule. Never agree to elective surgery in the room. Any surgeon who pressures you to sign on the same day as your consultation, that pressure itself is a red flag. Take 48 hours minimum. Write down your questions. Sleep on it. Fear of the condition should not override a measured decision about the treatment. Bonus number 2, always request a pre-surgical cardiology clearance. I don't care if you've never had a heart problem. If you are over 65 and facing any procedure requiring general anesthesia, a cardiologist should review your case. Your surgeon may not request this automatically. You can request it yourself. It takes one phone call. I've stopped 3 surgeries in the last 2 years that would have been catastrophic for the patients in front of me. Surgeries other specialists had already greenlit. Bonus number 3, ask specifically about anesthesia type. For many orthopedic and urological procedures, regional anesthesia, a spinal block, an epidural, a nerve block can be used instead of general. Regional anesthesia carries a fundamentally different cognitive risk profile for older adults. Not every procedure allows it, but many do, and many patients are never told it's an option. Ask the question, is regional anesthesia an option for my procedure? And if not, why not? You deserve a specific answer. Now, I want to stop here for a moment because something important needs to be said. That 74-year-old retired school teacher, the one who came in holding the surgery consent forms, didn't have her operation that Thursday. She postponed it. We spent 6 weeks optimizing her medications, reviewing the surgical evidence, and consulting with a second specialist. She asked the questions I gave her. At the end of that process, she and her new surgical team agreed on a modified, lower-risk approach. Different surgeon, different technique, regional anesthesia. She called my office 8 months later. Her daughter sent a card. In it, she'd written, "Why didn't anyone tell us to ask these questions before?" That question stays with me. It's the reason I do this. Every single one of these 5 situations shares the same fundamental problem. A rushed decision made without full information in a system that doesn't always have time to provide it. Remove the rush, add the right questions, and the outcome changes. 5 different procedures, one common thread. Slow down, ask more. You have the right to know. You can start that process tonight. Let's bring this all together because I don't want you to leave with a list you'll forget by tomorrow. 5 surgeries, 5 conversations. 1. Spinal fusion for back pain. Ask about the non-surgical pathway and comparable outcomes data before agreeing. 2. Elective stenting for stable coronary disease. Ask whether you are treating a heart attack or treating a number on a scan. 3. Knee replacement. Ask about a structured prehabilitation program before committing to surgery. 4. Carotid endarterectomy for asymptomatic stenosis. Ask whether your stenosis is symptomatic or incidental. It changes everything. 5. Any elective surgery under general anesthesia after 75. Ask about regional anesthesia alternatives, cognitive risk, and cardiology clearance. That's it. 5 questions, 5 conversations. No exotic supplements, no expensive equipment. Just the information you were never given in that 15-minute appointment. Now, here's what I want you to do right now. Pick just one of these that applies to you or someone you love. Not all 5. Just one. Maybe it's a procedure that's already on the table. Maybe it's something your spouse was just told they need. Maybe it's a conversation you've been putting off having with an aging parent. Just one. Take the question to your next appointment. Sustainable change starts with one small decision made with courage. Not tomorrow, tonight. Which of these 5 is most relevant to your situation right now? Tell me in the comments. I read every single one. If someone you care about is sitting on a surgical consent form without this information, share this with them. This is the conversation they deserve to have before they sign anything. And subscribe if you haven't. Every week, I'm here with honest information that I wish every one of my patients had access to. No agenda, just the science and the truth. One last thing, and this is important. Everything I've shared today is general information based on current research and my clinical experience. It is not a replacement for your personal medical care. Please do not stop or change any medication without speaking to your doctor first. Bring these questions to your next appointment. Have the conversation. Your doctor is your partner in this, and the best partnerships are built on honest, informed dialogue. The research on anesthesia and cognitive aging in older adults is something thousands of people have told me genuinely changed how they advocate for themselves. I highly recommend you watch that next. I'll see you there.